Is my screen visible, sir?
Yes, yes, it is visible.
Sure, sir. So I'll just thought I can share whatever we do for augmenting trochanteric fracture, sir. So basic idea is this was a patient whom we had. This was 3 years back. It was a trochanteric fracture. We routinely do nails for these trochanteric fractures, and when we did this BMD, we have found this T score was below minus 2.5, and we were seeing this X-ray at 1 month follow-up. So this made us really think could have been done much more better or something else to prevent this happen. So this patient underwent a totally pre-placement. So yes, definitely we have changed from where we were to begin with earlier. So we have started to analyze the fracture patterns in much better way. So we do these AO classifications, we understand the fragmentations, we understand the way to reduce them. So by as Rastogi sir told us, actually the whole story starts once you position the patient in your traction table. You understand what is the fragment and how are these fragments getting pulled each manner, and then you use the appropriate reduction techniques like what we have been discussing also far. And then, however, whatever you do, the implant related problems are still persisting. We have a lot of implants that have come and then gone out. Like we have a DHS. They're very good when they're used in fracture patterns, and you have failures also. And there is a common concept that the 84% of our failures are due to cutout. That can lead to mechanical instability, revision surgery, and gradually it increases the mortality and morbidity. So yes, we have also evolved with better instrumentations. Now we have more anatomical nails, we have more good reduction tools, we have the blades which have come up to increase your holding capacity. But still, even with the blades, also you have the back out and the penetration, which are very common. Again, I mean, as a whole percentage, they're still happening. So poor bone stock is one factor which we don't have a control actually. Even though our understanding of the fracture has got better, our instrumentation has got better, but poor bone stock is universal. And in India, being having a more of a geriatric population, this will remain a challenge for the next, say, 30 to 50 years, definitely. So if our options can improve in this aspect, we thought we can do a better job in fixing these patients. So there are a lot of biomechanical studies where cement augmentation improves the holding area of the implant. It reduces your chances of failure. That normal varus collapse, which can happen, needs almost 346 times increased amount of cycles to produce the same varus collapse. So this was proven by biomechanical studies. And the better implants that has come out, blade with the fenestration to accommodate a cement at the end of your head, so that it improves your holding capacity. So this also the studies are there where it works better. So this is a case example where you have a 74-year-old female, unstable trochanteric fracture pattern. You see the CT scan, this amount of porosity that is there. So once you position, you understand this has a large medial void. You do a open reduction and you transfix as Rastogi sir told us, and then you do a circulars where just to make it remain stable. And then the sequential steps which we routinely do for all our trochanteric nailings are done. But the end of fixation, again, if this holding capacity is increased, then your chances of failure would come down in a very gradual way. So that's what we did. And this is the post-op X-ray. So this cementation technique is quite a easy one. So this is how the cement kit looks like. This comes with Synthes actually, and this is the cement powder that is there in the device. I can show you a small demonstration of how do we do this cement actually. So it is again the same like we do in a replacement. You have a monomer, which is the liquid, and you have the polymer, which is the powder. The mixing of monomer and polymer is first done together, and then you gradually load them in syringes. So basic idea is we need to have at least 4 cc of cement across the the fenestrated blade, so that you have a good holding capacity. The first thing is mixing, like how you do a manual mixing in your arthroplasties. We can do controlled mixing using this device which they give, and you do with the monomer and the polymer. So it is done sequentially for 25 cycles. So it becomes a very good paste like consistency. The next step is filling up the syringes with this paste actually. So this is just a technical trick where you'll have to avoid air, and then gradually load the syringes. So you have 4 syringes, so you fill up gradually. And this is the cannula which is there. So the very important essential step is, before you start to do this cement, you have to make sure that there is no intra-articular penetration of the cement. So you use a die, like you use an arthrogram, and if there is no penetration into the joint, then you can confidently go ahead and inject the cement there. So this is done gradually. This, you can see, this is how we start. And gradually, when you start pushing, you can see the cement gradually getting spread across the blade. So that is how it goes across. And you make the patient walk full weight bearing from day one. So these patients do better when they are walking full weight bearing. So this is the short video how this is exactly done. So another case example where you see a very porotic, a very similar 95-year-old lady who had a trochanteric fracture. We again did a wiring, and we did a cement augmentation. This is at 6 months follow. So yes, we know this has been also studied in literature. The cutout rate has come down quite significantly when this cement augmentation is used. And this study by Dennis et al. In 2022 stated the failure rate was 2% compared to 13% in a non-cemented group, in particularly in osteoporotic fractures. But this is, you should be careful that the intraoperative joint penetration of a cement is a very dreaded complication that we should not have, and dye injection before you inject the cement is very essential. And it has no use when it is used in non-osteoporotic bone. In fact, it becomes very tough when you have to have a situation where you try to use it in a non-osteoporotic bone. Your resistance is very high actually, so you may not be successful in injecting them. So to conclude, this cement is a very valuable tool in an armamentarium, and it's very important to understand that we need to use this rationally and not on a routine basis. And this will not replace your good reduction. This will not replace a very good implant. This is just an additional tool that we use, and it is definitely costly when you take it with a normal nail. But however, think about a fixation failure, it is definitely a more costlier treatment option, which is going to be there if there is a failure. So just to prevent, like what our theme is, doing it right first time. So the cement augmentation holds in line with that. So that's how this works. Thank you, sir.
Thank you, Dr. SIVAKUMAR, sir. Just
Yeah.
for your nice demonstration of the procedure. But I have one question on this. Instead of using cement, can you use stimulants, like it is coming from that that way biodegradable? That
Yes,
because
sir.
is that will helpful in some way? Because in I have used couple of cases in like distal radius fractures, proximal humerus fractures. I used to inject the same thing around the implant as a filler. And as you know that later on helps in bone formation and also stimulate this osteosynthesis. So what is your input on that?
The stimulant actually, it's biodegradable, sir, and as you told, it degrades and does not form a new bone actually. So
I
other
think the
option what we have.
Gen X is for that purpose, for stimulant. No, it's not stimulant as such. Okay, you are putting antibiotic, but for a Gen X, you meant
Yes,
to say, so that is purely for, I think, bone growth stimulation.
yes, sir. Yes, sir. The cerament we can use, sir. We can use it. It forms a new bone in 2 years' time. But
Yeah,
then the challenge would be how we are going to get it into the neck. That is the challenge that we are going to face. If it's a paste-like
it's a
consistency,
paste. It's a paste only. It's a paste,
then
and it's a paste, and also it comes with a pre-filled syringe. Here you need to
okay,
prepare it, but it comes with pre-filled syringe. I've used couple of times, but I don't know,
okay.
but not have a very good exposure. Maybe 4 or 5 cases I've used till now, and but wanted to know just like whether really they work or not. Or I've just exploring few of the methods. I've tried those methods, and mostly in case of proximal humerus fractures, there you don't need had a trajectory to push it. You can push it directly, and for distal radius fracture, it is everything in front of you. Not that in the neck of femur you have to pass through that blade plate, all the stuff. So here I can put directly. So maybe I don't know if others can give some idea into it.
I've seen a few cases where in infective non-unions, in addition to the antibiotics, these also can give a bone filler, sir. There it works, but it has to be done under direct supervision, visualization.
Okay.
So, not sure about in other implants, sir.
One more question. Is there
Sir.
any difference in cementing what you do? Like you fill it early, and the way we do it in arthroplasty, that till the time it is not sticky, we are not allowed to touch it. So, is there any difference? Is the rules are same for cementing the?
Almost same, sir, but this the time required is much longer here. It takes almost 20 minutes to become completely set. So you have a long time to instill it within the blade.
And
Although it
which
doesn't take
cement
a
you
lot
use?
of time. Sir, it comes in a pre-filled pack actually. The same Synthes guys gives this actually.
Okay.
So,
So it's
Thank
at
you,
the
Dr.
liquid stage.
SIVAKUMAR. Sorry, sir. Please go ahead, sir. Kapil, sir, please go ahead.
It's at the liquid stage when you fill the syringe, right? It's not
No,
that.
sir, it's again a paste actually. It becomes a paste in just 25 cycles of manipulation.
Okay. Thank you.
Shiva sir, one question.
Sir, please.
If at all you face a situation where the patient falls again after this
Okay.
fracture and there is a tough cement inside it, so will you like the patient will have a very complex fracture then, and I think the removal of the implant will also become very difficult. So have you faced such a situation?
Sir, touchwood, I have not faced it till now, but what the literature tells is removal is easy. The removal is not as tough as what we think of removing a cement from an arthroplasty situation or doing a revision THR. So, touchwood, I have not done it till now, but the minute I do it, definitely I'll get back to you and I'll give my personal opinion on it.
Basically, cement implant interface is the most easy to take it down rather than cement
Bone
bone
interface.
implant. So,
Yeah.
so that should not be, I think. It's a good.
In that
Thank you.
scenario,
That's
Gen X will be better because it will absorb by the time the patient falls next time.
Yes, sir. And one more thing, Gen X, I think if you can, after you drill it and if you push it inside and then put a blade,
Yeah, that is better option. That is better option. You
rather
can.
than going through the holes,
Yeah,
probably.
that is better option, sir, because there you can put more amount of Gen X
Gen
into
X.
the holes. Yeah. Thank you, SIVAKUMAR sir, and we're coming to the end of this session with the last talk by none other than the organizing of this webinar and who is running a fracture license service in AIMS Bhubaneswar. That's basically so he will be speaking on that particular topic: osteoporosis management, fracture license service, and secondary fracture prevention. So, Dr. Gunjar, I think you will conclude with this talk. Go
Yeah.
ahead, please go ahead.